present on or summarize a session on management of ACS and antiplatelet agents. So first and foremost, we welcome you to our channel, sir, and we request you for the discussion on such a topic so that the fraternity can get benefit out of that. So sir, before proceeding, I would like to ask a basic question. What is ACS, if you can explain?
Yeah, good morning Atul and Rahul, and thanks for inviting me to summarize my views as well as whatever were discussed in the CSI conference on acute coronary syndrome. Actually, in simple language, acute coronary syndrome is chest pain. A lot of patients come with the symptom of chest pain, but all those who have a cardiac pain need a very urgent and aggressive management. A lot of patients ignore chest pain and take their own time to contact a doctor. That should not be done, because even if 99 out of 100 patients don't have cardiac pain, one life can be saved. So acute coronary syndrome is a chest pain, classically a cardiac pain. There can be variations, but classically it is a retrosternal severe chest pain going either to the left or both the shoulders or the epigastrium or the neck and the jaw, with or without perspiration. This is the definition of angina pectoris. So chest pain which presents in a patient with or without risk factor should be investigated as urgently as possible. Once the patient reaches the hospital, a provisional diagnosis of acute coronary syndrome is made, and when an ECG or the blood reports are done, immediately we categorize this acute coronary syndrome into acute ST elevation MI, unstable angina and non-ST elevation MI. So any chest pain basically till diagnosed should be labeled as acute coronary syndrome till the investigation help you to categorize further.
So sir, if a patient presents with such kind of symptoms to a family physician, then what is a role of family physician to be taken in such kind of situations?
Now, first advice to a patient is don't ignore any chest pain. As soon as you get a chest pain, immediately either call your family doctor or go to a family doctor, go to a family physician if you have what is called a practicing physician in internal medicine, or go to a nearest hospital where at least the diagnosis can be confirmed, because again time is muscle, time is not money. So diagnosis and further management is extremely important. Now, a lot of people nowadays know that if a clinical diagnosis of acute coronary syndrome is arrived at, they give the patient a cocktail of 3 medicines, what are called antiplatelet medicine, because the theory of acute coronary syndrome is a rupture of a vulnerable plaque followed by formation of a clot which obliterates the artery partially or totally, and that's how the categories of 3 acute coronary syndromes are made. Is a total occlusion, it becomes an acute ST elevation MI, which classical ECG findings. If it is a partial occlusion, it may be non-ST elevation MI or unstable angina, and accordingly there will be ECG changes. ECG diagnosis is important. Now, family physician has to give a pain relief. He can give him sorbitrate, and a lot of people who know about this particular condition also give the patient aspirin, soluble aspirin of 300 milligram, clopidogrel 300 to 600 milligrams, and either 80 milligrams atorvastatin or 40 milligrams of rosuvastatin as a strategy, because atorvastatin will stabilize the plaque, the antiplatelets will further prevent formation of the blood clot. So afterwards, whether it really turns out to be an acute coronary syndrome or not is a different issue, but patient does get benefited. So after the family physician, the role comes about the internal medicine or the physician, so to say, and then if the patient goes to a hospital, he is taken care of by the hospital itself.
Great, sir. So sir, we also would like to understand that what is this pharmacoinvasive therapy?
Very good, because now once the family physician has suspected that it must be like an acute coronary syndrome, because the problem with him is that he cannot confirm by an ECG. A lot of physicians have an ECG machine, but when it comes to referring to an internal medicine physician, I'm not talking about cardiologist, This is quite possible in our country because there may not be a cardiologist available, or there may not be a center where invasive facilities available like a cath lab. So this is the time consuming process during which the family physician and a general physician can help the patient. Now they have to decide, the internal medicine physician helps in diagnosing the case. If it is ST elevation MI, you have to be more aggressive. It is non-ST elevation MI or unstable angina, he at least can send the cardiac troponins and other cardiac enzymes to decide how early patient needs invasive treatment. But most important and urgent invasive treatment is required for ST elevation MI. Now ST elevation MI is something where the muscle is dying every second, every minute. So he has to decide a strategy. If the patient needs an acute intervention like PAMI, primary angioplasty in myocardial infarction, there's a short form PAMI, you must have a cath lab available in the nearby area, because we call what is called a golden hour. Unless the patient reaches the cath lab within 90 minutes to 120 minutes and an angioplasty is performed by opening the artery, then only the muscle can be sandwiched. But if for some reason, say traffic, say distance, cath lab facility is not available, or patient mentally or financially not prepared for primary angioplasty, which is obviously an expensive procedure, there comes the role of the general physician. Once he is diagnosed with ST elevation MI, he has to check whether patient fits into any of these. He is not going to a cath lab center. I'll treat him myself with thrombolytic therapy. That is called pharmacoinvasive. That means you salvage the patient in the early hours before he can reach a cath lab center. And there you have a choice between streptokinase and tenecteplase. Streptokinase has been a very old drug, very cheap, but it was in the form of side effects like allergy, hypotension. It has to be given in the form of an infusion. Tenecteplase becomes a better choice, although expensive, can be given as a bolus, and that improves the patient. Lot of patients, their ST segment settles down, their pain settles down, and you get a time for sending the patient to the next center, what is called tertiary center, primary, secondary, tertiary center, where the patient can be taken up for invasive strategy, followed by what anatomy we get on coronary angiography.
So, that was really a very great management insight, sir. So sir, once all these conditions are crossed, now there comes a role of interventional cardiologist. So what exactly is the role?
Yeah, the first thing is to do coronary angiography, and as per the findings of the coronary angiography, you can suggest the treatment to the patient. Again, it falls into three categories. One is if the patient has a critical blockade of 1 or 3 coronary arteries, he has to decide the culprit artery, the artery which is responsible for an acute myocardial infarction should be tackled first. And then if the patient is stable, nowadays a lot of data has come, there has been a controversy between whether to tackle only the culprit vessel or you do a full revascularization. So there are points in favor, points against, there are data in favor and against, there are articles in favor and against. But ultimately the decision has to be with the interventional cardiologist. If he is confident enough to take care of all the blockade, he can go ahead, provided life of the patient is more important. There are situations where it is suggested that you tackle the culprit vessel and then go for the other in the same admission, same index admission, either same index procedure or same index admission, which can be done anytime after 48 hours to 1 week, or it can be staged to 6 weeks also. So this decision is taken by the interventional cardiologist. Now most important thing is the loading of the patient. If the patient is going for an intervention, lot of general physicians load the patient with antiplatelet agent. That's a good thing, because as I mentioned earlier, 600 milligrams of clopidogrel will prevent formation of the clot by inhibiting the platelets. Aspirin soluble also plays the same role, but acting at different level. And the statins stabilize the plaque. So this is already done either by the family physician or the general physician. So that makes our job very easy. So we go ahead with an coronary angiography followed by an intervention. One word of caution is, now we have 3 antiplatelet agents. First one was clopidogrel, then came prasugrel, and now got ticagrelor. Now clopidogrel takes time to inhibit the platelets completely, up to 4 to 6 hours, even if we load the patient. Prasugrel is more potent than clopidogrel, but the recommendation for prasugrel is that unless you have coronary anatomy, you should not load the patient. If a patient is loaded by clopidogrel, nothing goes west, nothing happens to the patient. Prasugrel, unless you have a coronary anatomy, and if you are going to perform an angioplasty, means that again the logistics play a role, whether the patient is willing or not, and all those things. So clopidogrel takes a back seat. Ticagrelor is the most potent one that is available now with us. Very fast acting, and the effect also goes faster than clopidogrel or prasugrel. So that is an advantage for ticagrelor. And the another advantage, even if the patient is loaded with clopidogrel, we can still use ticagrelor, because knowing that clopidogrel is going to take 4 to 6 hours for complete platelet inhibition, we give the advantage to the patient of ticagrelor, which is more potent and which can be continued. 90 milligrams, 2 tablets can be given as a loading dose, and subsequently the patient can be continued with same drug. So this is the greatest advantage of clopidogrel. But the word of caution for the family physician and the general physician is that once you give ticagrelor to the patient, you cannot thrombolize the patient, because it's a very potent antiplatelet agent. On top of that, if you give thrombotic therapy, then you will face a disaster by bleeding complications. So family physician or a general physician should, in consultation with the cardiologist and considering the feasibility of going for an invasive treatment, then only you should give. Yes, I am sending the patient for angioplasty, I have prepared the background, his patient is willing this, then it can safely be given. But definitely if you are planning for thrombotic therapy, then ticagrelor should not be given. You can give clopidogrel, give thrombotic therapy. Subsequently, if the patient goes into, there comes the pharmacoinvasive treatment. The patient has been treated with thrombotic therapy because of the logistic problems. Now he comes to me, then I have a choice to decide whether I switch over to ticagrelor or otherwise and continue that. This is extremely important. So once the patient coronary angiography is done, we feel confident what is to be offered to the patient, and then what is to be continued with the patient. So when it comes to discharging the patient, we continue with ticagrelor 90 milligrams twice a day, continue with high dose statins, and aspirin 75 milligrams. This is another thing, because ticagrelor is a very potent molecule. We don't give 150 milligrams of aspirin because of the fear of bleeding. And this is called DAPT, double antiplatelet therapy, which has to be followed for at least 1 year. And those who continue with ticagrelor, there are studies which suggest that after 1 year, you can step down to 60 milligrams of ticagrelor twice a day for the next 3 years, which further reduces the incidence of myocardial infarction or any acute coronary syndrome. Another word of caution, or rather a warning to the patient, that never discontinue your ticagrelor, not even 1 tablet. Always keep a stock of 10-20 tablets at home, because 1 dose which is missed can produce an acute clotting of the stent, and patient may not reach the hospital also. Acute stent thrombosis is common where patients discontinue antiplatelet agents, and therefore this warning has to be given to all the patients, whether they undergo invasive treatment or whether they undergo only thrombotic therapy and continue with the medicines.
Right. So sir, it is said that ticagrelor has reversible binding at ADP P2Y12 receptors. So how does this really help in comparison with clopidogrel, which is an irreversible binder?
Yeah, that's why clopidogrel takes more time to have the effect nullified. Same thing with prasugrel. The advantage with this key, even after loading with 2 tablets, and if we do coronary angiography and then for some reason patient is not willing for any invasive treatment, we can discontinue that and continue with other antiplatelet agents. This was a problem where they were, the clopidogrel, ticagrelor was very expensive, but now the more companies are manufacturing that, the price is not the issue. Most important thing is that patient is already loaded, and I have done a coronary angiogram and I feel that this patient is not suitable for interventional treatment like angioplasty and stents and requires bypass surgery. The surgeon can take up the patient as early as within 48 hours. The main fear with the surgeons with antiplatelet agents is the bleeding. So if the first thing that they ask is what antiplatelet regime the patient is on. If he is on clopidogrel, I can't do with till 7 days. If he is on prasugrel, I can't do 5 days. But in ticagrelor, this particular property helps you to take up the patient as early as 48 hours.
Great. Wonderful, sir. These were very beautiful insights that we have gained today. And we really thank you for being a part of our channel today. We also request the audience or the viewers to address their questions in the comment section below, which can be looked forward in the future. And we thank you very much, sir.